So obviously this is my second Facebook Live for today. So I'm sure you heard, or if you're watching, you probably know that we started doing antibody testing for the COVID virus in our practice. We started yesterday. We opened it up to other people in the community, people who are not our patients today. And the response, both in terms of interest and questions and people who want testing, has been really overwhelming. And so usually at 3 o'clock, I kind of run through data and current stuff going on about COVID. What I'm going to do tonight for the first time is do really kind of a PowerPoint presentation and actually present some data and then take your questions. So wish me luck. I'm going to try to show a screen here. Okay, everybody, we'll try this one more time. Okay, so the problem is going to be that the slides are going to be pretty small now, but let me try to explain what it is, and I will put the slides on my website so you can take a look at them after, and I'm so sorry for the technical issues. Okay, so what this picture is trying to show, if you look at the 4 lines going across, is what happens with COVID infection. And we know that if we take 100 people and we infect them with COVID, not everybody has the same experience. In fact, we know that about 25% of people, we think, may change a little bit as we have more antibody data, have really no symptoms at all. We know about 50% of people have mild to moderate symptoms. They feel like they have the flu. They have a fever for a short period of time, and they're sick for 1 to 2 weeks, actually on the long side. So very different than influenza. This is a much longer infection. And then 15 to 20% of people are the ones who have serious infection, who have hypoxia, can't get enough oxygen, they're very short of breath, they end up in the hospital. And then 5% are really the patients who are very, very sick and end up in the intensive care unit, and many of them on ventilators. And so what you can see by this, if you're looking along the bottom, it's the days that are there. And what you're looking is when you are first infected, so that's day 0 there in this picture, you will start shedding virus and your body is starting to have an immune response. Now, you typically don't have symptoms for 5 days or so, and then you'll get the fever. And at that point, again, you're still infectious. Right at the top, you can see, and it's small for me as well, but a line that looks at about where you have viral shedding. And in the majority of people, it's probably 14 days. And I talked about this a little bit on previous Facebook Lives. In very sick hospitalized patients, they've detected the virus particles really as long as 30 days. But what this is trying to show is that you have different categories of the way that you are infected. Okay, so that's one of the reasons, and I talked about it on the Facebook today, that we think that there's age is a big factor, genetics, what underlying conditions you have, all contribute to kind of what your response will be. But we don't understand it perfectly, obviously, because there's young people that have died from this as well. And it relates to that big inflammatory reaction that we've talked about several times. Okay, so I'm going to keep going on slides here, and let me show you this. So this is really what I want to talk about. Again, the slide is small, which I'm sorry, is to talk about what happens from that point of infection, and then what happens in terms of your body's antibody response. So if you see at the bottom, there's a line that shows when you are shedding virus. And you can see that really, if we say the day that you develop symptoms is day 0 in this model, you're shedding virus for a couple days before you actually have symptoms, if you're one of the people that are going to develop symptoms. And you can see at that point that soon after you get the fever, your body then, of course, is trying to clear the infection. You will have that red line there, which is the IgM antibodies. And that's the body's first response. And we see this with all kinds of infections, not just with COVID. IgM is the acute antibody response that you see. Later, you start to mount the IgG antibody response. And this is the antibody response that you want, because this is the type of antibody that confers long-term protection. And what is long-term with COVID? We're not entirely sure. But the hope is, because this is a very stable virus that doesn't seem to be mutating, we hope that, once you've been infected once, it's going to confer long-term protection, and you're going to have persistent IgG antibodies. And so when we're thinking about testing right now, the testing that's been out there that I've done in practice for other people that is available but in short supply across the state and across the country is when we do the deep nasal swab We send the swab to a lab, and they test it for the presence of the RNA virus itself. That's the gold standard test. If that test is positive, it tells you that you have an acute infection. And again, when someone presents to the hospital or they're sick, that's what we really want to know. Do you have an acute infection? The test looking at antibodies really isn't the right test to tell if you have acute infection, right? So if you're sick with a fever and you're in the emergency room, antibody testing is probably not the right test. And I'll tell you why it's probably not the right test, because you might be able to see IgM antibodies, which would tell that you had an early infection, but you might not. If you're very early in your infection, you can see there with the fever, you may still have no IgM antibodies. So when we test for antibodies, again, you have to remember what information you're getting. We're looking at the body's immune response, not the actual presence of the virus. Okay, so this is one other slide I just want to show you here. And again, this is really hard to see, but what it's really talking about on this slide is, and I can't really blow it up, but on the left-hand side where you have the arrow that's going down, that's really looking at the viral infection itself. What you see at the end when it's going up, they're trying to show, and that graph going up, is the inflammatory response and what's happening in those patients who have the really serious response. This is really an inflammatory mediated process that leads to the terrible lung disease and cardiac disease that we've been talking about in these patients, in about these 5% of patients who get so critically ill. Okay, and the slides are small. This is a slide again, and they're small, and I will put these on the website. And I'm so sorry this didn't work the way that I thought tonight. Really just showing that age is the biggest predictor of mortality, but it's not 100%. So you can see in the very older people at the right that the mortality rate can be as high as 13%, but in younger people, it's much lower. And it's slightly variable depending on which country we're in. And I've been reading some things today just about what makes Italy, why their mortality rate seems higher, and that's because the population is very, very old in Italy. One of the reasons we think is that because their average age is higher, but we don't completely understand it at all. But clearly, age is a predictor of mortality. Okay, so what about antibody testing? And again, this is probably a hard to read slide, and I apologize, but the top bar where you see the FDA is what I want to talk about, which is this emergency use authorization. And on the right, I've taken a screenshot of where I went to the FDA website to actually look to make sure that the company that I purchased these test kits from was doing this the right way. So on March 16th, the FDA took a very dramatic and I think clearly needed approach to help us in this country during the pandemic, make testing more widely available, really to loosen restrictions, and in fact, loosening restrictions on telemedicine. So doctors could do telemedicine in different states was one of the other things that happened during this time in our country's attempt to rapidly change the way that we were doing things to improve care of patients. And the FDA, who, and I'm very evidence-based medicine, and I really want, prescription drugs, when they go through the FDA approval process, it's all about looking at data to make sure that the drug that's being approved, is effective and is safe, and we know the correct dose. And that's really, really important. But what the FDA did on March 16th is really take this unprecedented step of loosening restrictions, because at that point we were just having a terrible time and still a shortage of testing. So the FDA said, hey, we realize we need to engage the private sector. We need to make it easier for companies to commercialize testing and to get it into the hands of the people that need it, even before we go through this lengthy FDA approval process. So they put out this emergency use authorization guidance. And what that has done is allow companies, private companies, to commercialize testing that has been validated elsewhere, and in this particular case in China, and to bring that into the United States and commercialize it without formal FDA approval, without waiting the months and months and months and months to get FDA approval. And so this company that you can see there, Premier Biotech, brought in the test kits, the antibody test kits, not the test for the virus, into the US and was allowed to commercialize it. And you can see I checked at the FDA website that they had done their due diligence, that they had submitted the appropriate documentation to confirm the test, and then it was available. And again, as I've said in a previous Facebook Live, one of the advantages of having a small independent practice is I could really be very engaged in this, and I really quickly got access to this testing, purchased it from this company to make it available to my patients. But again, I want to clarify, the test is legal and appropriate to be commercialized according to the FDA guidance. It is not an FDA approved test yet. Now, I will say one other thing about that. There is a test that you may have heard, an antibody test that was FDA approved a couple days ago, and that's by a company called Cellex. That is not the same antibody testing. So that antibody testing is a blood draw, an actual blood sample that you send to the lab to do the same antibody testing, but it's not this rapid test that I have in my office now that I'm doing for patients. Okay, this is a really, really small slide, but what I got some questions from physicians about this. I've seen a bunch of chats about these tests on social media now from other physicians in physician COVID chat rooms now, really saying, well, hey, what's the sensitivity and specificity of these tests? Well, what does that mean? It means if you get a positive result, is it really positive? If you get a negative result, is it really negative? Can you really test the results of this test? And I will tell you, like any test we do, any test, your cholesterol test, your thyroid test, your blood count, whether or not you do a rapid flu swab in the office, all tests are limited by a specific sensitivity and specificity. And you want tests to have very high sensitivity, meaning that it's sensitive. When it's a positive test, you really have the disease. And very specific, meaning if you have a positive test, it really means you have that specific disease. And I will tell you that this test, this is data that was presented in their FDA application to get this waiver to be able to commercialize it, suggests that this test is highly sensitive and specific. Now, not perfect. So first to tell you that, there are going to be a small percentage of false positives and false negatives. But again, it's in the range of other diagnostic testing. Oh, I want to do one thing here to make it a little bigger. Okay, so what's happening in the office? So interestingly, I've gotten a ton of text messages today from people who are not my patients. My cell phone number was given to people from friends or patients, or I'm not exactly sure how, but people have been texting me, asking me how they can get the test. If you are listening out there, what I would please ask you is, if you have any friends or family that you talk to about the testing and you want to get the test, please have them go to the website. I have spent a ton of time putting videos on the website and a ton of FAQs, information about the test itself, that if you read that, you will absolutely learn all that you need to know. I put those graphs on there, and I've done some videos about the process. And the bottom line is this we really want to do correctly. We want to do it carefully, and we need to have patients or community members call the office and schedule. Please do not show up at the office unannounced. There are forms online that you can print, because it would be easier for us if you actually printed and signed some things and read some stuff before you came to the office. But we're doing it outside in the back part of our office. I'll show you some pictures, and you definitely need to schedule. Okay, so these are the test kits. This is what it looks like. So you can see that these come in completely contained kits. And what's in them is the actual cartridge, where we put 2 drops of blood and then develop it with some liquid. We've got a timer there because we set a timer so that we give it appropriate time to actually develop. We put your 2 drops of blood, we prick with a finger. It's like a finger stick blood glucose. We take really 2 drops of blood and a little pipette. We put it in that cartridge with some solution to develop it, and we wait to see. So there's a control line at the top, which means that the cartridge is working, and we wait and then see if there's any other lines that show up. 1 line for IgM, 1 line for IgG, and if you have both lines, then you have both antibodies, which some people do. And then this is what our process looks like at the office right now. And again, I'm sorry, the slide is really small. So the picture on the top left is really the front part of my office. And I put that there just to say, please do not come to the front part of the office. We really again, are working very hard right now to protect patients with social distancing and keeping the office really clean as to the best of our ability. So we have, as I've said many times, one dedicated room for anyone that's coming in with flu-like symptoms or sick that we have any concerns about at all, that we really keep clean. Our 5 other exam rooms are really for other things, broken ankle or, something else that someone needs to come in for urgently. And we're really keeping them separate, and we're only having one patient in the office at a time. What we've decided to do with the rapid testing is have people drive around to the back of the office, and we're actually having patients stay in their car. So please stay in your car. If you can print information from the website or that we email prior to you coming, that would help us out greatly. It's just a consent form and a questionnaire. We will take your pulse ox and your temperature, ask you some questions, prick your finger, do the test, and send you on your way, and then we will communicate with you with results. And so we've been doing this for 2 days now, and it's going pretty well. Please be patient with us because it's very labor intensive right now for us. And again, please don't show up and call us before you come. So with that, that's all I want to go through there, and I will certainly take your questions now. Okay. All right, we will make the slides available on the website. Okay, from social, what percentage of people who go on a ventilator actually get better and survive? So this is really one of the most depressing things about this illness. There's so many things, right? So we don't really understand why 5% of the people get so sick and end up on a ventilator, and they do, and they can be young. It's more common if they're old, but this is really a bad thing when you are in that 5%. And why is that? So with a typical pneumonia or typical congestive heart failure that we see all the time, when people are intubated, put on that breathing machine, it's generally very quick. I mean, 1 day, 2 days, 3 days. You're not generally on ventilators for weeks and weeks at a time. And in this particular illness, the inflammatory response is so bad, and the damage that happens to the lungs is so significant, and the degree of difficulty we have getting oxygen into the tissues and the length of time it takes to recover means that people are being requiring ventilator support for 18, 20, 22 days. It's really, really long. And with that, every day someone is on a ventilator longer, the mortality goes up. And you add to that that this is a very serious infection with, again, cardiac issues related to it, that the mortality really we're seeing is at least 50%, and I've seen other statistics out of other places that it can be as high as 80%. So again, the mortality is very, very, very high. And, so it's a bad thing. If someone, I was talking about Boris Johnson, unfortunately, it sounds like he's going to make it through this without actually needing to be intubated, again, with the little bit of information that I have. But going on a ventilator increases mortality dramatically. Okay, will you also offer the CellX test in your practice? Okay, so the CellX test is not, it's been approved, but as far as I know, I use LabCorp in my practice. I have not seen that LabCorp has made that serum test or the serum test available yet. It is very clear to me that very quickly now, the next 3-6 months, there will be several new FDA-approved antibody tests available and commercialized, and it will become widely available. And what I would tell you is, again, I go back to, I really want to believe in data, and I really do believe that we need to have FDA-approved testing, and that what I'm offering right now is, I believe, validated and appropriate to be doing, but it's not an FDA-approved test, and it's giving some information, but probably not everything. So what I really believe is that for patients who have positive tests and even people who have negative tests, it probably is that in the next 3 to 6 months, we will be doing either the CellX test or another test to do confirmation of antibodies and have a better sense of what level antibodies you need to have to confer immunity and how long those antibodies are going to last. I have had in the testing I've done the last 2 days, a couple patients, actually one physician that's positive for IgG right now, and he had a very clear infection relatively recently. And so the good news for him is that really does right now confer protective immunity for him. It's a recent infection. And so with him on the front lines, he can be really pretty confident that he's been exposed and he's not going to get exposed again. He's been through it. And so that's where it's very helpful. But in patients right now where their antibodies are positive, and we don't know what's going to happen in 6 or 8 months, is that adequate to confer long-term immunity? We don't really know yet. But by that point, I believe there'll be FDA-approved tests that we will offer and repeat in the office, just like I do other lab tests with LabCorp. This test right now is a way to get information into patients' hands quickly, again, as this world is evolving and things are changing. Okay, IgG levels pretty constant after 30 days, or do levels continue to steeply decline with a person? Would a person who had exposure more than 30 days ago still have detectable IgG? We absolutely believe that you should have detectable IgG within 12 months probably right now. So we do know with certain infections and with certain vaccinations, hepatitis B vaccination is a good example, that many times we don't, years after hepatitis B vaccination, if we check serum IgG antibody levels in a patient, they may not be detectable. But what we've actually learned is they have kind of hidden immunity, and so that patient is still really for lifetime protected against hepatitis B. So what we just have, this is a novel new virus. We just have no idea yet if that's going to be the case for this. And that's where really, again, I would never tell any patient right now that this antibody test right now is the last test that they should do if they have positive antibodies, right? This is going to evolve because we really don't know yet level of antibodies, duration of antibodies, whether or not someone who has undetectable antibodies 5 years after having positive antibodies, if they're still going to be protected. We just have so much more that we need to learn. But I would tell you 30 days, they should still have positive IgG. Is UC or any of the other hospitals using plasma as a treatment? Okay, so I saw something today out of Johns Hopkins that definitely using the plasma of people who have been previously infected, who have IgG positive antibodies, that seems to be the most effective therapy right now for patients who are critically ill. From what I can tell is you have to go to the blood banking system to find out how to actually donate plasma and where they're doing it. And again, I do not have a patient who I've referred to do that yet, so I don't know the exact process, but I was looking at it today on that Johns Hopkins article about the study that they're doing there and the data that's coming out of there. Under what circumstances would you have someone get the viral RNA test versus the antibody test? Would you have anyone do both? Okay, so remember, if you're sick and you have symptoms, you need the RNA test. Now again, I say you need it. You need it if you're really sick. Right now, if you're mildly sick, we don't have great availability of it in the city. It's really hard to get. And so again, if you think you have it, the best thing to do is to stay home and self-quarantine if you have mild symptoms. At the end of your infection, so say you've been sick now for 5 days, I would tell you to self-quarantine, and you're not very ill, but you feel flu-like, self-quarantine for 14 days in 2 or 3 weeks. If you want to do the antibody test and see if you have IgG antibody and confirm that that really was COVID, that would be an appropriate thing to do. Now, you ask, would I ever do both? So the issue is this. Yes, I would do both, and I've sent one patient so far from the testing in the last 2 days to get a confirmatory RNA test. So think about this. This particular patient had positive IgM antibodies. That's that acute one, suggesting that this patient was early in her infection. The problem, of course, is the patient is a healthcare worker. So now what do you do with that information? The patient is a healthcare worker. She's not ill. She has a little bit of symptoms, but she's really not sick. And not sure that the symptoms are really COVID, right? I mean, she's maybe a little off, but she certainly didn't have fever. So the issue is, do you tell her, yes, that's absolutely, you have COVID and you can't work and you have to stay home and you have to self-quarantine? Well, the reality is it would really be better to know if she's in that small percentage of people that had a false positive test. And so with her, I really went through the steps to refer her to get a confirmatory test, because if she had a false negative, then she could go back to work, right? And so that's a circumstance where knowing the data immediately was really, really important. For people who have, and I've had a couple today who have positive IgG, the presumption is if they remember that they had an infection that fits with the story, then that makes sense. That's, certainly that they had COVID. If they have absolutely no symptoms, they don't think they were sick, and they have positive IgG, they probably had an asymptomatic COVID infection. But again, that would be someone who I would suggest probably in 3 or 6 months when we have the FDA approved testing should get retested. Okay, would you recommend basic chest physiotherapy for asthmatic COVID patients to possibly prevent pulmonary complications while ill at home? So I will tell you, I don't really know how to answer that question very well. So I've seen different things, frankly. I've seen some people talking about, and again, this is really largely from what I've been looking at the the COVID physician groups on social media, is that there's the people that believe that really you need to rest and you need to not add any additional strain, don't exercise, don't do anything if you clearly have COVID. There's other people that really do, again, positioning you and physiotherapy, chest percussion that we do in the hospital may be appropriate, but again, I don't really feel comfortable telling you clearly one way or the other, and I don't think there's great data about that yet. Are there any medications that we should stop taking? Anything that makes us more susceptible to contracting the virus and or having a more severe infection? So that goes back to ACE inhibitors and ARBs. Those are two classes of blood pressure medicines, although there's some little data out there that maybe they're a problem. There's some other data that says that maybe they're beneficial, and the cardiology world right now has said don't stop taking them. We don't think there's enough data. The other big concern has been about anti-inflammatories, and again, for me, I think there's enough data for that to just say, since Tylenol can be a substitute for most patients, I think you should switch to Tylenol and not take Advil or Aleve. It came up in one of the previous Facebook live groups about taking baby aspirin or aspirin in someone that's got known coronary heart disease, has had a prior stent or a prior heart attack or a prior TIA or stroke. In that circumstance, the benefit of aspirin far outweighs any potential downside of taking aspirin, and I would encourage any patient that is on aspirin for secondary prevention of cardiovascular disease should stay on their aspirin. You spoke earlier today that the clinical study was awaiting IRB approval. Once approved, will that antibody test be free of charge to study participants? Well, I wish that was the case, but that's not true because there's no grant funding for the study to cover the cost of the testing. So I spent a lot of money to buy the testing. So the IRB approval, when it's approved, will allow me to really look at the data in a very specific way to kind of compare the levels that I'm seeing in the population of positive antibody tests and really compare that to the rate of positive tests that we're seeing, that they're getting in the hospital right now in the sick patients, and actually see if there's a difference. And it will help us understand, better understand the number of patients that really have completely asymptomatic infections and have positive antibodies. And again, I really wish that I had a research study grant to cover the testing, but I don't, and so I'm sorry that that's not the case. How do you find out where antibody testing is available? I live in Northwest Ohio. Right, so this is really hard. I will tell you, even in Cincinnati right now, and I'm in the mix of all of this, right? My husband's chair of emergency medicine at UC, and so I kind of have the inside scoop of what they're doing with testing. I certainly am all over social media watching this. I can tell you that there's at least 2 places in Cincinnati that are doing this same type of antibody testing that I'm doing, and I certainly see it in other parts of the country. I don't think there's a great registry for this at all. I will tell you really transparently, I reached out to Governor DeWine and Dr. Amy over the weekend before figuring out how I was going to operationalize this and really offer this to patients, to really ask the question of whether or not there was any reporting mechanism for me in the state of Ohio if I got these positive tests. Who should I be reporting them to, right? So the tests that I've gotten, and it hasn't been a high number so far, but those aren't included in our data right now, right? So if I have positive antibody tests, it's not the same as positive RNA tests, but still, I think these are people that have been infected, and it would be nice to start to have a registry of those, but there isn't as far as I know, and I don't really have any way of telling you who in Northwest Ohio is doing this kind of test. I can see from what's going on in the next 2 to 4 weeks, there will be lots more places where this is happening. And then again, I'm hopeful in the next 3 to 6 months that there's the FDA approved, again, which should be covered by insurance at that point, right? So this is really just ahead of that. Okay. For your antibody study, are you looking to enroll subjects who only think they had symptoms for COVID? No, absolutely not. So the way that I'm doing this is I opened it to my patients randomly. I opened it to the community randomly. So these are people self-selecting who want to have antibody testing. And it is completely not based on symptoms. It's not based on age. I'm trying to get a big kind of random sampling of at least the population around me, around my practice, who hears about this, to come in for testing, to give a kind of very general sense of what's going on in the community. So again, it's a very different population that I'm looking at compared to the patients that my husband is seeing in the emergency room who are getting tested, right? So those are the patients who are sick enough in that graph that I showed at the beginning. Those are the patients that are sick enough to end up in the emergency room, and they clearly look like they have COVID and they're getting tested. So the percentage of patients is much higher. What's going to be interesting to see is how much higher in my community sample is that if we're testing more people who don't have symptoms. You might as miss this one. What about taking arnica? So I don't, again, I'm not in the place of making recommendations about supplements in general, and I don't know the data, frankly, about arnica, and I don't know if anyone else who's listening does, but I don't specifically know about arnica for this. How far out are you scheduling for testing now? Is it days or weeks? Will the tests run out? Well, for sure, I don't have an unlimited supply. I ordered quite a large amount, expecting that there would be a great deal of interest in this, and also wanting to have a good sample size to make the data for the study kind of reasonable, right? Because you have to get a random sampling, you have to have a reasonable size. But my expectation is, based on the rate that we're going now, I think we'll have enough testing probably through the end of April. Right now, I think we're really booked tomorrow and Friday, and I think we still have spaces, obviously starting next week. So again, please just call and make sure you schedule prior to coming. Please do not show up. And we are letting people bring multiple people in a car, but if you schedule and you can't just bring 3 other people, because we have really a system of making sure we have the test kits really out and organized well so we can do this as efficiently as possibly. And again, we have to have PPE and just a whole lot of things. So please schedule. If one tests positive with the antibodies testing, is it safe to conclude one would not need to be concerned about exposure to the virus? So if you have IgG positive antibodies and you don't have IgM, that really tells us that you have cleared the infection, you have protected antibodies. And at least for this, when I say relatively short period of time, I would say for the next 6 months to 12 months, we know that you're protected. And you're really not at risk of going to Kroger's, for example, to get re-exposed. Now, again, because this is not an FDA-approved test, because we don't have definite data to tell us how long antibody protection lasts, what level of antibody protection you need, I would still say that even a person who I'm testing who has positive IgG, although I'm comfortable saying you have IgG antibodies, you had an infection a couple weeks ago probably, that's not to say that I would tell you that you shouldn't be social distancing and you should just be willy-nilly, but at least not yet, until we have the more confirmatory test that I know is coming. But it is reassuring, right? So I think you wouldn't have to be quite as concerned about social distancing and kind of coming in contact with someone who was infected. About the arnica, so yes, I certainly know that it's used as a different anti-inflammatory. The same person wrote the question. I have no idea, though, if it has a mechanism of action like Tylenol or Advil, and if there's any reason to think it would be safe or better than Tylenol or Advil. I mean, in my world, I would say I stick with what I know, and I would say use Tylenol and not the arnica, but again, it's not my area of expertise for sure. Okay, any other questions? All right, great. Well, I really appreciate everyone's time. And again, I'm so sorry today has just been a terrible day with ridiculous technical issues. So anyway, thank you very much. My husband will be joining Facebook Live tomorrow. He's been working in the ER, working really hard this week. So he will have some data about life in the ER and kind of what he sees on the front lines. And that's tomorrow at 3 o'clock. And I hope you'll join us then. Thank you.